Hi, it's Dr. Centeno, and sorry for the time mix-up today. I think it was advertised at 9, and I had planned to do this at 10. So a little time mix-up there, but we got it worked out. So today we're going to talk about an interesting topic. I ended up talking to this last few weeks at least 5 or 6 patients who all had surgeries where various parts and pieces were removed, and none of them really knew that things had been removed. These were all craniocervical instability patients looking for relief. They had all had one surgery or another. One had a styloidectomy, another one had a C1 shaving, another one had had a Chiari decompression, and they really had no idea that each of these surgeries removed critical stabilizing tissue so that whatever their craniocervical instability was before these surgeries, it was clearly going to be more after the surgery. So none of them had gotten relief from these procedures. That's why they were contacting me. And so I wanted to talk about this idea that there are no spare parts. And what I mean by there are no spare parts is that each part in your upper neck is there for a reason. There's nothing vestigial. There's nothing that can be removed without causing more issues. Now, surely there are times when surgery is needed to remove this or that. But what's removed has to produce less of a problem than the issue it solved. And that's the balance that's difficult with surgery, right? We've got to thread that needle between removing some critical part and making sure that that removal doesn't make things worse overall for the patient. So that's what we're going to talk about today. We're going to talk about those 3 different procedures: styloidectomy, C1 shaving, or it's actually called a C1 lateral mass decompression. That's done for internal jugular vein compression, just like a styloidectomy is. And then we'll get into finally Chiari decompression surgery and what that's all about. As usual, we'll start with a short presentation, and then we'll get into questions. And you can ask questions about this topic or really anything else that strikes your fancy. So let me go ahead and get that presentation loaded. And I will share my screen here. Okay, so I'm going to get into this topic here. Okay, so this is there are no spare parts, CCI edition, styloidectomy, C1 shaving, and Chiari decompression. And what I mean by there are no spare parts is, again, this last couple of weeks, I spoke to 5 or 6 different patients, all who had one of these 3 procedures or more. And none of them really realized that things were being removed that were critical for stability. And as you know, I try hard to make sure everyone gets educated on these things. There are certainly times where these surgical procedures need to be done, but patients also need to be informed about what's happening. And none of these patients seem to understand that critical parts were removed that were involved with stability. None of them seem to be able to understand what that meant. So again, these past few weeks, I've had a run of these patients, hence today's discussion. So what we'll discuss: styloidectomy, C1 lateral mass decompression, also called the C1 shaving, and then a Chiari decompression. So styloidectomy and C1 lateral mass decompression or C1 shaving, both of those are really the same, or at least dealing with the same issue, right? The concept is that there's some compression here of the internal jugular vein. We've got the styloid in the front, and we've got the C1 transverse process in the back. And you can see that there's some decreased flow in this internal jugular vein here. The problem with both of these surgeries, and I've really brought this up now multiple times during Facebook Lives, is that they both treat a problem that's very common in asymptomatic people, meaning people walking around out there that have any age. Anywhere from a third to 1 in 5 have from moderate to bilateral severe internal jugular vein stenosis and don't know it. So we have to be careful when we see findings like this on imaging to ascribe symptoms to it, because there's no test I can give you or any other doctor can give you that can prove that what we're looking at right there is causing your head pressure and headache. I want to say that again. There's no test available that anyone can do that can prove that what we're looking at there, some compression in internal jugular vein, is causing your symptoms. Unlike other things where there are tests that we can do to see if this or that is causing your symptoms. So for example, if I think your symptoms are coming from the right 0-1 joint, I can numb up the right 0-1 joint and see if your symptoms go away. Can't do that with this. So the only way to really see if this is causing your symptoms is to get a surgery to open this up. And you can open it up from the front side, which is styloidectomy. You can open it up from the back side, which is C1 lateral mass decompression. Now, styloidectomy, here's some of the anatomy here. What you're really removing is this calcified stylohyoid ligament here, and or stylomandibular ligament. So the bottom line is you're removing more a ligament that's been calcified than you are the styloid itself. But notice that the single overarching thing here is that we've got this styloid process and all these things that connect into the hyoid bone. So really, all of these structures, the stylohyoid muscle, the stylohyoid ligament, are really connections for the skull into the hyoid. And that's going to become important when we look at what else is connected to that hyoid. So I've drawn in the hyoid here, and you can see we've got the sternohyoid, omohyoid, all of these muscles that basically are anterior stabilizers for the neck. So remember, we're cutting the connections between the skull and this hyoid bone, and then this hyoid bone connects into all these anterior strap stabilizers. So basically, I'm destabilizing your anterior neck stability system when that styloidectomy is performed. Now, why is that important? I'm not sure if any of you've probably seen these sculptures. They're in airports. Suspension bridges operate on very much the same principle. But as you might imagine, if you see this sculpture in an airport, right? If you were to go up and cut one of those wires, it's called a tensegrity structure, and each of those wires provide tension, hence the word tensegrity, and that tension is necessary for the overall stability of the structure. So if you cut one of those wires, which is what styloidectomy is doing, that whole structure is no longer going to be stable. It's going to become unstable in specific directions. So the body is filled with these tensegrity structures. So if we start cutting the styloid, we cause instability. Now we're going to switch to C1 shaving or C1 lateral mass decompression. So this is the C1 bone here. I've drawn in the area of the lateral mass, and that's the area that's generally shaved down in the C1 lateral mass surgery. The problem is, again, there's a lot of stuff that attaches there and near there. If we look off to the right, this is the atlas, but it's really how the atlas appears in real life. You can see that there's all of these ligament and fascial planes in here that all connect to each other, that provide stability between the atlas and the skull, and that provide stability between the atlas and down. So if I've got to shave that area off surgically, I've got to cut into that stability system, and then I've got to shave some stuff down, and then I've got to put it back together. Well, it's not going to have the same tension. It's not going to really heal like it was before. And depending on how much I have to remove, there may be permanent damage to those stability structures. So what happens during a Chiari decompression? Well, really, as you can see here, this is a patient after a Chiari decompression. What you're looking at there is this is the back of the skull. That's the back of the brain. This thing here is some wire mesh that was placed in, and this is the dura that's now pouched out or pushed out. Now, that's what was removed. All of that bone there was removed. So the bone should go all the way down to about right here, but now it stops way up there. So Chiari decompression is basically putting a hole in the back of the head. So the most common surgery would be that they take out this piece here. They take out the back of the atlas as well, back of the axis. Sometimes they just take out this piece here. But look at all these muscles that attach right there. These are the muscles that stabilize your head on your neck. And look at the posterior lennooccipital membrane, which is just on the other side of the dura. That can get damaged too. So the bottom line is there's just no way to remove this bone without also destroying the active muscle stabilization system for the skull or head on the neck. So in summary, there are no spare parts. You can't remove tissue that supports stability without also causing more instability. Hence, before these surgeries are explored, please look at all non-surgical options where the goal is to strengthen tissue rather than remove it. And listen, there may be times when there's no other way to get that person well but to take out that tissue, but it should never be put in front of a less invasive procedure that hopefully can strengthen that tissue to provide stability. So let's stop there and see if I've got any questions. Got a bunch of questions. So I will go back and take the first questions first. Here, let me get out of my sharing mode here. It's been advanced by Lee Phillips. Hi, I have spurs on my lower back region, which is causing spikes of inflammation. Spurs don't cause spikes of inflammation. Additionally, the peak doctor has identified low bone density in the lower vertebrae. I'm 55 years old with PRP, help improve my condition. Yeah, bone spurs are there to try to stabilize the spine. So oftentimes they're not the villain, they're just an innocent bystander. So I would have to look at your specific issue to know whether or not a platelet-based injection would help. Also realize that it's not just PRP, it's exactly where the platelet-based injection is placed. So if you go into a chiropractic office or an office that doesn't have a physician super specialist that can do x-ray guidance with contrast and ultrasound guidance, you're not going to get anything anywhere near a structure that will help you. You're just going to get ripped off for a really expensive PRP trigger point injection. So be careful there. Maria, is it okay to take PPQ and aloe vera juice according to the Cusack protocol when doing PRP or stem cell treatment? Or can those supplements interfere with stem cell treatment in a negative way? I don't know that either of those would interfere with stem cell treatment in a negative way or PRP. Jessica, have you ever heard of 15 degree C2 rotation? It's possible to fix something like that. Yeah, Jessica, I'm not really concerned at all about the amount of C2 rotation. Obviously, if you're a chiropractor trying to get alignment, then obviously that would be helpful in trying to determine exactly what force vectors you need to use to try to get alignment of C1 and C2 rotationally. But there's nothing about a 15-degree rotation that concerns me, meaning that if we take 100 patients with scoliosis off the street right now, they're going to have 15 degrees or more rotation, and none of them have upper cervical symptoms. So the rotation isn't the issue. The instability is the issue. Regenetics been advanced by John Gardner. Hi, if the odds of needing more than one PICL is 20%, would your percentage of only needing one increase if you had an injury less than 3 years? No, yeah. The only thing that determines one treatment in my clinical experience is if we get someone within 12 to 18 months of the injury. So if you have been injured 3 years ago, you're going to get quoted 2 to 4 treatments, which is everyone that isn't in that 12 to 18 month range. Dachasha, lots of questions. Sorry, can you explain the impact of chronic infections and CCI? I don't think there is any impact at all between chronic infections and CCI, meaning that we have no data that allows us to tie any chronic infection to causing craniocervical instability at this point. And I think right now, until good data is produced that connects those two, it's a red herring. So if you have been told that you had an infection that led to your craniocervical instability, it's possible, but we don't have any data that connects those two things. So that's anyone's guess as to whether or not that's possible. Jessica, is it okay to wear a soft collar a couple hours a day? Not really. If you're wearing a collar, the ideal use of that collar would only be for situations where you know you're going to get thrown out or jostled about, for example. So let's say you know that every time I take let's say you lived out in the middle of nowhere, right? And you've got a 10-mile dirt road in order to get to the highway. And you know that every time you go over that 10-mile dirt road, you're getting jostled about. Great time to wear a collar, and then you take your collar off. Or every time you're in a plane flight, so you only fly a couple times a year. So a couple times a year, you wear a collar during a plane flight. Or if you're in big crowds, it's easy to get jostled, let's say in the subway. Again, when you're in the subway, wear a collar, but then take it off. So 3 hours a day is far too much collar use. It's going to lead to less muscle mass, which is going to cause more instability. AT for myself with CCI, there's muscle compensation from lats and traps in regard to PT. Should strengthening core lats and traps be fully avoided until CCI is fixed? Yeah, you don't need to strengthen your lats and traps, so to speak. If they're already in spasm because of the CCI, you'd want to focus on the small muscles up here to try to get them to do their job so the big muscles stop overworking. It's been advanced by John Gardner. What would make someone a better candidate for posterior injections over PICL, even if they have overhang? John, if they've got pathologic amounts of overhang, which is more than 3 to 4 millimeters with an asymmetric interval between the atlas and dens on lateral bending open mouth view, then in general, in my experience, posterior injections will not work, or at least they'll work only about 1 in 5 times. That patient really needs a PICL procedure. So hopefully that answers that question. Natasha, DMX completed. Are there any other tests that would be good enough for a neurosurgeon and yourself recommended? Would have to pay out of pocket, so trying to get one that covers for everyone. Well, DMX is important for us. If you wanted to get another test, that would be probably second most important for us. And I think the neurosurgeons that specialize in CCI, and there's only 5 of them worldwide, meaning if you're just going to see your local neurosurgeon, not a good fit for CCI, you're going to have to see one of those 5 surgeons worldwide. There's 4 in the United States, 1 in Europe. And so that would be a flexion extension MRI. A seated flexion extension MRI would probably be the next best thing. Raj, hi, doctor. What are vascular headaches? Are these different types of headaches caused by blood vessel abnormalities or pinching? Are the different types different CCI headaches, and which is more nerve? Vascular headaches are usually migraine headaches. There's a completely different mechanism for migraine headaches and musculoskeletal headaches, which can be due to everything from facet joint irritation in the upper neck to, for instance, occipital nerve irritation at the back of the skull here. So vascular migraine headaches are very different than neuromusculoskeletal headaches, which are due to problems in the musculoskeletal system, like craniocervical instability or injuries to those joints, for example. AT, 7 weeks out from PICL, fair to assume second phase ECM deposition is complete. Now in the final phase of collagen reorganization. Does being more physically active help with this? Yeah, I think that's pretty reasonable to assume that that's probably where things are. And in that case, again, threading the needle between staying as active as possible but not pissing things off is really the key. Being as active as possible without really aggravating things. Jessica, it's possible that alar ligament being super overstretched or snapped could cause such a rotation in the C2. Yeah, it's possible, but the rotation number tells me nothing, meaning it doesn't tell me anything about instability because, like I said, if I take 100 people with mild to moderate scoliosis off the street, they're going to have that same degree of C1 rotation, but none of them have any symptoms. So again, it's not really a helpful piece of information for me at all. Regenix been advanced by John Gardner. Can a bulge of 5/6 be treated at the same time as PICL? It can be, for sure. Smith advanced by John. Already got that one. Length of time, person's after plan for coming to Colorado, pre and post length of stay, activities to avoid, pre and post, what activities pre and post do persons need to avoid? Yeah, so Natasha, if you're a domestic patient from the US, then the recommendation for the first procedure would be to come out the day before and then get yourself settled here, then come in for initial hands-on evaluation. And then after the initial hands-on evaluation, you would then do the bone marrow bone marrow aspirate, and then come back in the afternoon for the PICL procedure. Then you'd be sent off to PACU for about an hour and then sent home. Normally, we want you here for 1 day afterwards so that we can see you in clinic if we need to. That only happens about 1 out of every 10 times that we need to see that person back, and then you can go home the day following. Now, if you're international, we'd want you to have a few more days here after the procedure for that first time until you get a good sense of how you're going to recover. Obviously, once you get a sense of how you're going to recover, meaning if your patient's like, recovery was really no big deal, then you can compress that time frame quite a bit. Hello, Greece, AVM in the thalamus. It's been advanced by John. Do you have any thoughts on mouth appliances being prescribed by PRI doctors to help Atlas stay in place? Yeah, I think as we've talked about, there's this connection between the upper cervical spine and the TMJ in that they talk to each other and they rely on each other. Do I believe that you can fix a upper cervical spine by a mouth appliance? Not really. I think you're just going to offload it for a little bit, and then you get dependent on the mouth appliance. While it may provide some temporary relief and it could be helpful in trying to get the person more active, it doesn't really fix the craniocervical instability issue. Natasha, where's your history working with Canadians? Your reports, etc., being recognized by Canada. Appears Canada, our health system, does not believe this CCI-AI and the MRIs, DMX, no coverage. Natasha, we treat lots of Canadians. I would agree your health system is not set up to handle issues like this, not only issues like this, but many issues. I would be agnostic to what the Canadian health system thinks or doesn't think, right? At the end of the day, my goal is to try to help patients, and we help a lot of Canadian patients. I don't know that any of them have ever tried to get their Canadian health system to recognize this or not recognize this. My Canadian patients are just looking to get relief, and they can't get it in Canada. Raj, doctor, before that is, you treat cervical facet joint pain by cutting the nerves in the neck around the causal. You said it was not a good idea. Why does it affect nerves, give stability? Yeah, I think you're talking about radiofrequency ablation. So radiofrequency ablation is when the nerves, the medial branch nerves that take pain from the facet joints, are literally burned via a probe where the tip of the probe heats up and ablates or kills off the nerve. You could say it cuts the nerve, but it probably more accurate to say it ablates the nerve. Now, the problem is that nerve also provides innervation to the stabilizing muscles. And so if we destroy that nerve, then the muscles that are supposed to help stabilize go offline. So not a good thing, because stability is half ligaments and half muscles. So we really can't create a scenario or a situation where we are getting rid of the nerve supply to the muscles, because that makes the instability worse. It's been advanced by John. How important to see Dr. Rosa and have that imaging for PICL? You know, John, there are lots of patients that we qualify for the procedure with, say, for example, a regular MRI and a DMX. Now, where Dr. Rosa's expertise comes in handy is Dr. Rosa can identify various parts and pieces that might need additional attention that we may not see on regular MRI and DMX. So I will always take Dr. Rosa's opinion on what needs some attention where, which is really where I think Dr. Rosa comes in. In addition, obviously, Dr. Rosa's flexion extension MRIs by themselves, even without a DMX, can sometimes get to instability. And then we'll get a DMX on top of that. But that's how Dr. Rosa and I have always worked together. Zach, can DMX identify instability, loose ligaments in the thoracic spine? No, really can't, based on my experience. Megan, I've got CCI 2A2B, post-PICL about 9 weeks. I'm having a problem when I sleep where my chin is tilting up, causing my head to look up, which is terrible for me and causes a major flare-up in my symptoms. I'm waking up for the pain. It's almost like the muscles in my neck tighten and pull my head back up, so my head tilts up. I used to recommend cervical pillar, but it isn't helping. It's normal part of the healing. Is there anything I can do to prevent it? Let's see, Megan. Let me see if I've got information on you or not. Yeah, Megan, I think the best I could tell you would be that it looks like, well, it's impossible for me to get into your confidential health information here, but I can say that you might want to consider wearing a cervical collar only when you sleep, kind of like a hard collar, to try to prevent that. You're still in that time frame where we really don't look at outcomes until about 3 or 4 months after a PICL. But based on what I'm seeing, using a hard cervical collar while you sleep may be a good idea. And then obviously reach out to whichever doctor provided your procedure directly, so that if there's any other specific information that doctor can give you, that happens. AT, just a quick update, Doc. Continuing very aggressive all treatments discussed while managing flare-ups, curve correction. Great. It's been advanced by Harry Winston. Should we assume that doctors in Europe claiming to do PICL procedure have not been trained by you, or have you trained doctors in Europe to do this procedure? No, I've trained no doctors to do this procedure. There are no doctors in Europe or elsewhere that have been trained to do PICL by myself, or that I would send a PICL patient to. This is a very difficult procedure to do. In fact, as you've probably seen with the EPICL, one where we're still making leaps and bounds improvements in the procedure as I learn more and more about how to place the needles, how to confirm where we are, new procedures for getting to specific parts and pieces and spots. So no, there's no one in Europe that's been trained. There's no one outside of Colorado that's been trained to date. That will certainly come online at some point, but not until everything is all dialed in. And it wouldn't be a see one, do one, teach one, meaning it wouldn't be someone showing up and watching a couple of procedures. The person that I would train on how to do this would have to spend months learning how to do this before I would feel comfortable. And that's a hard thing for physicians, right? They want to go and take weekend courses to learn how to do something. This is not the kind of thing you can ever teach in a weekend course. That would be completely irresponsible as a doctor, because there's just too many moving parts. Maria, it seems clear that styloidectomy can worsen CCI, but how much can affect subaxial instability? Well, it depends on what kind of instability you have in the mid or lower cervical spine, right? So if we're talking about instability or retrolisthesis in extension, then it's could have an impact on that, because you're taking out the anterior strap stabilizers, for example. Ian, what are your thoughts about mold mycotoxin exposure causing connective tissue issues in CCI? Ian, we have no data at all that connects CCI to mold or mycotoxin exposure. So I would say it's a guess, right? I can't rule out that 10 years from now, someone might come out with some very well done research that connects mold and mycotoxins to CCI, but right now we have no information that connect these two dots. So we don't even consider mold or mycotoxin exposure in what it is we're doing, because there's no rational explanation of why one would cause the other. And there's no hard data on why that would happen. So I'm agnostic to it. I ignore it. Natasha, DMX confirms instability, neurocognitive vagus nerve, motor control with arms and legs, blanking out, can't afford SX. I don't know what SX is. What do you recommend? Thank you. I don't know what XS is here, Natasha. Maybe treatment, TX, that could be. Yeah, Natasha, I'm not quite sure what to tell you there. Obviously, we have some online exercises that you can try. Upper cervical chiropractic can be very helpful for symptom relief. That's another thing to consider. So those are things to think about, but I think you mean can't afford treatment, but I'm not sure. Raj, hi doctor, what's treatment you would offer cervical spondylosis? That just means arthritis in the neck. So I would need to know a lot more information about what we're dealing with there before I can make any kind of recommendation. Stephanie, Catherine, what about bilateral internal jugular vein compressions? One side over 90% occluded between C1 and calcified styloid, stroke risk, too late for injections. 1 in 5 patients with 0 symptoms and no problems at all have bilateral severe compression. So I'm not concerned about bilateral severe compression, because there's lots of people walking around with it who have no symptoms, no problems, live normal, healthy, productive lives. So again, Stephanie, I want to make sure that you hear that. 1 in 5 patients who are imaged for something else in their neck, where they can look at what's happening with the internal jugular veins, have severe bilateral stenosis. So it's possible that the severe bilateral stenosis could be causing symptoms. It's possible that the severe bilateral stenosis combined with instability could be causing symptoms, meaning the severe bilateral stenosis by itself doesn't mean a lot, but when you add in the instability, it gets worse. But it's also possible the severe bilateral stenosis is a total red herring that has nothing to do with anything about why you get symptoms of head pressure, tinnitus, etc. So be really, really careful with that information, meaning that there's nothing about severe bilateral stenosis when it's found in 1 in 5 people without symptoms that should be a concern for anybody, unless we have very hard, credible information that that's causing your symptoms. And regrettably, the only thing we can do is to decompress that and see if your symptoms go away. But by decompressing it, we're making you more unstable. Natasha, can you explain the feeling at my cervical spine feels like vertebra turning and choking me out? Natasha, I need to know a lot more info to answer that question. Turns inward, chronic convection, just wondering regarding Centeno side of inflammation, did I misunderstand? Yeah, so again, Natasha, chronic inflammation is a problem of our industrialized society, where people get too heavy, exercise too little, etc. That causes everything from heart disease to joint arthritis, etc. That being very different than some sort of chronic infection, meaning that there is no relationship that's out there that's credible that shows that any kind of infection causes CCI. Brian, your DMX measurement's a little overblown. I heard it's made to show damage for a car accident court. Yeah, Brian, that's, I think, my biggest criticism of DMX reports. DMX reports come in 2 types, right? The kind that Dr. Katz puts out, which are these, very clinical, well, here's all the measurements, here's kind of what I think they mean. And then we've got what I call the damage reports, which frankly, in my opinion, are a little irresponsible. These are, these reports where, this is damaged, that is damaged, this is damaged. We got the yellow highlights. So yeah, I mean, what I focus on in DMX reports is which of these measurements is most likely to explain craniocervical instability and whether this person could have symptomatic craniocervical instability. The rest of it is interesting, but frequently the rest of it is super common in anyone who's got degeneration in their neck, right? If I take 100 people off the street who are 50-year-olds right now, and we run DMXs on them, and if none of those people have any neck symptoms, we're likely to find about 1/3 of them that'll produce a really nasty looking DMX report in the lower and mid cervical spine. What would be more rare in that 100 people would be 4 millimeters of overhang when they shift their head to the right. And would also be rare would be having dizziness and headaches dependent on how they turn their head. So yes, you need to be very, very careful with DMX reports. I am not a big fan of how many of them over-report things that are just normally found in people with degenerative instability as they age, as if these things are some sort of crazy damage. DMX, in your experience, what's considered mild, moderate, severe lateral overhang? Really no such thing, meaning that I don't think someone with 8 millimeters of overhang is any more likely to have symptoms than someone with 4. But I can say, as a distribution of the abnormal findings that we see, we probably see about 1/3 of our patients who have 3 to 4 millimeters of overhang, about a third of our patients that are in that mid-range, let's say 4 to 6, and about a third of our patients that are more than 6. In your data analysis, do you have patients repeat DMX to confirm stability? Not quite sure what it is we're analyzing there. If we're talking about making a diagnosis, there's multiple runs, usually 3 or 4, where someone is trying to see if they can get any instability to happen at C1, C2. So that's already part of the first DMX. As far as, do we see DMXs that are non-diagnostic all the time? I'll tell the patient that we've got to repeat it. And then do we have patients repeat it for clinical reasons after they've been treated? We do. But that's not the main reason. Meaning it's not the thing we do all the time, because that's exposing someone to additional X-ray radiation. Brian, I had 2 PICLs, 2 PRPs, doing much better, playing frisbee golf, running, biking, and lifting. Overhangs went from 4.8 to 2.3, 6.3, 9. I think DMX was a good choice. Yeah, Brian, again, if we are trying to see whether we're making progress and should we repeat a DMX, that's where I think repeating a DMX can be helpful. Where I like to do it less often is if just someone wants to repeat the DMX after each treatment. My concern there is we're exposing the patient to radiation, and that has to gain us something, right? So if we were already going to redo the procedure, pulling a DMX probably not a good idea. Meaning if you're pulling a diagnostic test, you only pull a diagnostic test if you think it might change your treatment plan. Natasha, huge thank you for your online download and CCI spine books, giving one to my GP. Sure. Hey, Brian, can you do me a favor? You probably have my email address. If you don't, I'll put it down here. But one of the things I've been really remiss in doing is getting testimonials for PCI. I get asked all the time on Facebook Live here, hey, where are the testimonials? So I can look at those. And I've just started asking patients for those, which is, again, not something I've traditionally done because we're working on the 3rd data analysis right now. So I've done more clinical data analyses and put those online than I have asking for patients to send me, here's what happened as a result of my PICL. So for anyone watching, you see my email address there. I just put it down. It's right here. That's the email address that goes directly to my desk. If you could, send me your testimonial for PICL, because I've just been remiss in collecting those. And I think it's important in that I've got people asking me for it, and I haven't collected them. But we see all sorts of great things happening, so I'm starting to collect them now. Ian, the instability I experience feels as though it is up and down, movement of the skull, or front and back movement. For example, if I go over a speed bump in a car with my head facing straight or in neutral, I instantly experience bobblehead and strained sensation symptoms coming from the back of the skull. Whereas if I turn my head left or right when going speed bumps, physically hold my head up with my hands. Yeah, so that sounds a little bit to me, Ian, more like a CCI type 1C. And that sliding of the skull on the atlas could also be a CCI type 1A as well. So those are things to consider. But usually it sounds like, based on what you're telling me, is instability in the frontal plane of the skull on the atlas. So those are the kind of things that we would look at a DMX for, or a flexion extension MRI, or both. Raj, after the PICL procedure, do patients feel that something has been injection in the back of their mouth or results slow and steady? There's certainly some soreness in the back of the mouth. For some people, it's mild. For some people, it's more. That tends to go away over the first couple of days. In most people, results slow and steady. Most common thing we would see would be some sort of honeymoon period, although it doesn't have to be there, where someone feels pretty good while things are swollen for 2 weeks, even though they might be sore. Then that goes away, and then we tend to see positive changes in the 3 to 4 month time frame. Jessica, what do you think that makes your head have that feeling that it's falling backwards? Yeah, that's that CCI type 1C. Usually it's due to injuries of the ligaments anteriorly. So ligaments like the AAOM, the SAAOL, and others that stabilize the front of the skull on the atlas, or going further down, what turns into the ALL at C2-3. Raj, regular MRI with CCA imaging comments, not sure CI, does that mean DMX? No, there's really no relationship between a regular MRI and a DMX in my experience. So we don't want patients to get MRIs focused on the CCJ, looking for changes in signal in those ligaments. We want movement-based imaging that stresses those ligaments to see if they're allowing too much movement. Kimmy, is 1A something usually treated during PICL? I've had my second PICL with you in December. I have a lot of problems with abnormal measurements in flexion. Would you like to do everything possible to address this while addressing my 2B as well? Yeah, so for 1A, we're frequently going after the PAOM and the tectorial membrane, Kimmy. So that can certainly be treated. I don't recall offhand what was treated in your situation, and I always try to protect, obviously, health privacy in these kind of public settings. Alexis, can damaged tendons pull on the mydural bridge and dura mater and cause neurologic symptoms? I think so, Alexis, or whether it's damaged tendons or hyperactive rectus capitis posterior minor muscle, or something else that causes too much pulling on the dura. Realize that we also have the vertebral dural ligament between C1 and C2 that also connects into the dura. So it could be C1, C2 instability that's yanking on the dura through that vertebral dural ligament. Zigzag, what would you inject if you were treating someone's TMJ? We usually inject the joint and surrounding ligaments. Sometimes also the temporalis muscle tendon above and below the joint are also common injection sites. Kimmy, I have problems with vertigo when lying flat on my back. This causes issues with craniosacral massage, PT, and sometimes being evaluated for AO adjustments. What do you think this causes while only laying on my, or cause that while only laying on your back? I guess, Kimmy, the question I would have is that if you control your skull flexion or extension when you're lying on your back, do you still get it? Or does it happen specifically because your skull goes into a little extension or into a little flexion when you're lying on your back? So I need to know a bit more information there. Sandra, how serious are these measurements, C5, 6, 9 millimeters? I don't know what it is you're referring to there, Sandra. Are you talking about translational instability at C5, 6? Are you talking about the size of the central canal at C5, 6? Are you talking about the size of a disc bulge at C5, 6? As you can see, lots of different things that 9 millimeters could apply to. Debbie Drong, what can a person do instead of nerve ablation in the neck? Lots of things. We don't recommend nerve ablation in the neck at all. I used to do a lot of radiofrequency ablation back in the day before we had better options. Now we've got much better options with orthobiologics. So PRP injections, for example, in the facet joints, much, much better solution than killing off the nerves that will then provide instability. So we haven't done a radiofrequency ablation in 15 years because 20 years ago it was a good option to treat someone. It can be effective, but the last 10 years, it's been replaced by orthobiologics like PRP injections. in our practice. And sitting here in 2024, it seems like caveman medicine to me to kill off nerves that are there for a reason, just to provide someone pain relief, when there are better options to get that person pain relief and perhaps help the joint in the process. Natasha, ballpark figure of cost for in-person appointment. Bring all my imaging for 2015. How long's the appointment? Not well in elevation now. Anything can help with the adventure. That you'll have to get that from staff, but if you don't have any, oftentimes that's covered by U.S. health insurance, meaning if they've got United Healthcare, Blue Cross Blue Shield, Cigna, Aetna, we're just billing that evaluation to them. If you're paying out of pocket for an evaluation like that, it's probably going to cost in the neighborhood of $300 to $500, somewhere in that range. But we are all, we maintain ourselves on all major insurances so that people can come in and get an evaluation, and usually it's covered by that health insurance plan. Alexis, when lying face down for massage or treatment, I get a feeling of being choked in the front of my neck. That could be, listen, lots of things could cause that need to get checked out, but that could be from anterior longitudinal ligament laxity, or ALL laxity. So that's something where DMX would be helpful to see if there's retrolisthesis, meaning one vertebra going backwards on another when someone brings their head back. Monkey Girl, I'm having issues with tearing and swollen optic nerves. Could you comment on this? 0.1, shift of 5 millimeters, 2.3, 5.2. I don't know, Monkey Girl, what those numbers refer to. So you're going to have to give me more information to know what those numbers refer to. So for example, at C23, you're talking about translational instability there. Or are you talking about something else? 0.1 shift of 5.5 millimeters. I don't know what that means. That's not a thing, meaning that's not a measurement we use to determine instability. You can certainly get swelling in the optic nerve from increased intracranial hypertension, which can sometimes happen in CCI patients as their internal jugular veins get intermittently compressed with the instability. As far as tearing in the optic nerves, that's something you need to make sure you get an ophthalmologist to check out, because that would be above my pay grade. Sophia, can atlantodental osteoarthritis be treated with PICL? We can certainly get into the atlantodental bursa there and the atlantodental joint. So yes, but really, if there's arthritis there, you got to ask yourself why. And that could be due to instability. So I'd want to see if there's instability, for instance, that we treat the instability while we are treating that atlantodental joint. Zigzag, what are some things you're excited about for your practice, the field of CCI, or just life in general? Let's see. I'm most excited about getting insurance coverage for orthobiologics. It's been a career goal of mine now for many, many years. It's a project I've worked very, very hard on and continue to work very, very hard on. Through Regenix, for example, we have 3,400 U.S. employers that'll cover this stuff, lock, stock, and barrel. That's exciting to me because that allows people who can't afford this stuff to get it through their health insurance. So that's probably what I'm most excited about. We're slaying those dragons one at a time. We're picking off companies one at a time. And so that's exciting. On the PICL front, I'm most excited that I have evolved the procedure another big chunk with the ePICL. And I think we're starting to see even better results with ePICL. And I'm also excited that we've got an upcoming paper that'll define some of these subtypes. And hopefully that gets the information out there to more doctors so that they can understand how to diagnose this early. Because when we see these patients early, because they get referred to us early, we can help them with much less effort than if someone's had this for 10 years and never really been diagnosed. Brian, how long till data analysis 3 comes out? You plan to verify data with a third party? I'm not sure what a third party is. It'll get published in a peer-reviewed journal this time. So maybe that's what you're talking about there. Yeah, so they're doing the data 3 now, or the third data analysis right now. I looked at it just this week, and they're going to be pulling some additional data points. We're going to try to get enough data so that we can go ahead and look at the various subtypes, meaning does a 2B respond differently than a 1A, that kind of stuff. Again, still not seeing a difference between EDS and non-EDS patients, so that's good to see. That's held up from the second data analysis to the third. And this one, like I said, will be published in a peer-reviewed journal. We submit it to a peer-reviewed journal, and then we wait. So sometimes that's quick. It happens in 3 or 4 months after we submit it. Sometimes it takes a year. It just is what it is. None of the journals are very fast. Sandra, disc bulge indents the ventral canal, thecal sac narrowing, central canal, maximum AP dimension of 9. Yeah, so anything below 9 to 10 could indicate that you have a congenitally small canal, or if that's just the diameter at where the disc bulge is, it just means that the bulge is pushing into the cord. Again, I'd have to see the actual image and interview the patient to get an idea of how big a deal that is for that particular person. Sure, Zigzag. Thank you. Okay, guys, so we're coming up on a full hour here. This is a good time to get your last minute questions in if you've got them. Want to thank everyone for watching today. We've been talking about that there are no spare parts. So please, before you get any parts and pieces removed, try to treat this without getting your parts and pieces removed. Please like this video. If you're on YouTube, like and subscribe. If you're on Facebook, just like it, because that's how we get the algorithm so that more people can see this kind of content, right? If anything I see with CCI patients is that they have a tremendous sense of community. There's lots and lots of groups they're a part of. They may be involved in more cervical medullary syndrome stuff, MECFS. They may be involved more in CCI stuff, but there's a tremendous sense of community in patients trying to help other patients. So if you really want to try to help other patients, like this video, subscribe, because that's what gets it out to more patients so that they can see it. And maybe they won't have as rough a ride as you did, for example, in trying to figure out what's wrong, because all of this stuff got put in front of them by the algorithm. So thanks so much for watching. Have a great week. I will be here next weekend, and keep an eye on that time. I might do it a little earlier because I'll be traveling next weekend, and it'll fit better with our travel schedule. Have a great week, and thanks for all the great questions. Thank you.